So this is the second lecture on insulin abnormalities in children. My name's Dr. Indy Banerjee. I'm a consultant in paediatric endocrinology. I'm based at the Royal Manchester Children's Hospital and Alderhay Children's Hospital. The learning objectives of this lecture are to understand some aspects of insulin physiology, type 1 diabetes and type 2 diabetes and insulin resistance, and also aspects of insulin overactivity leading to hypoglycemia in congenital hyperinsulinism. Let's now have a look at this question. Choose the correct statements regarding insulin physiology. Glucose enters the pancreatic beta cell by facilitated diffusion, mediated by glucose transporter GLUT2. Insulin secretion is regulated by enteric hormones such as glucagon-like peptide GLP-1. Proinsulin is cleaved into equimolar concentrations of insulin and C-peptide. Insulin has a longer half-life than C-peptide. The potassium-sensitive ATP channel regulates insulin secretion. We know that insulin is regulated by food intake, and insulin is regulated by hormones from the small intestine such as glucose-dependent insulinotropic peptide, cholecystokinin and GLP-1. Glucose entering into the cell is regulated by the transporter GLUT2, so answer A is correct. B is correct because of the enteric hormone regulation. C is also correct as proinsulin is cleaved into equal proportions of insulin and C-peptide. However, C-peptide has a much longer half-life than insulin, which has a shorter half-life at about 5 minutes. Therefore, D is incorrect. The potassium-sensitive ATP channel regulates insulin secretion, as we will see in the next slide. This is a cartoon of glucose entering into the beta cell and secreting insulin. As glucose gets into the cell through the glucose transporter on the cell membrane, it enters into glycolysis and Krebs cycles and generates energy packets in the form of ATP. The ratio of ATP to ADP stimulates closure of the ATP-sensitive potassium channel which sits on the cell membrane. Once this channel closes off, this leads to depolarization of the calcium channel along the cell membrane. As calcium gets into the cell, this releases insulin from the endoplasmic reticulum and leads to insulin being released into the circulation. Therefore, glucose and insulin secretion are tightly regulated by the ATP-sensitive potassium channel. This is a slide on insulin physiology. On your left-hand side are stimulant factors such as high glucose, glucagon and the gut hormones. On the right-hand side are inhibiting factors such as hypoglycemia. Please note that insulin behaves as an anabolic hormone and stimulates glycogenesis in the liver and muscle and inhibits fat lipolysis. Let us now examine this question regarding type 1 diabetes. Choose the correct answers from the list. The allele DRB10405 is associated with a high risk of diabetes. The longest groups of nucleotide repeat elements 5' of the insulin gene confers a high risk. Loss of first phase insulin response predisposes to beta cell injury. All cases are antibody positive at diagnosis. and the latency of development of type 1 diabetes is predictable? And the answers are A and B. The most important loci determining the risk of type 1 diabetes are present on the major histocompatibility complex on chromosome 6, in particular the human leukocyte antigen or HLA class 2 molecules, which are either DR, DQ or DP. The HLA molecules present peptides to T lymphocyte, and hence there is an association of immune function. A proportion of children with type 1 diabetes are genetically predisposed to type 1 diabetes. The longest groups of nucleotide repeat elements, 5' insulin gene, is known to confer a higher risk. However, not all cases of type 1 diabetes are antibody positive, as antibody positivity may occur at a later stage. The latency of type 1 diabetes is unpredictable. These are the stages in the development of type 1 diabetes. Some children have a genetic predisposition. The beta cell mass, which is on the y-axis, dwindles if there is insulitis and beta cell injury, at which stage usually children become antibody positive. Thereafter is the phase of pre-diabetes, where there is loss of first phase insulin response. And after a variable period of time, the child is diagnosed with a newly diagnosed type 1 diabetes. Type 1 diabetes is increasing. The incidence is roughly 13 to 15 per 100,000 children in the UK. As type 1 diabetes is an autoimmune condition, other autoimmune conditions are possible, such as hypothyroidism and celiac disease. The treatment of type 1 diabetes is with insulin, and regular insulin administration is critically important. There are various complications, most notably nephropathy. In the early stages you can get microalbuminuria, retinopathy and neuropathy, which are usually later. There are World Health Organization criteria for the diagnosis of diabetes mellitus. If the fasting glucose is greater than 7 millimoles per liter, and if the random plasma glucose or the 2-hour plasma glucose after administration of a glucose load, as in the oral glucose tolerance test, is greater than 11.1 millimoles per liter, then you have a diagnosis of diabetes, be it type 1 or type 2. Let us now come to the question in relation to insulin injections in children with type 1 diabetes. Choose the correct answer. A. Dose should be omitted with physical activity. B. Dose should be decreased with febrile illness. C. Preparations with human recombinant technology have reduced incidence of lipoatrophy. D. Non-compliance with injections is a rare cause of diabetic ketoacidosis. And E. A persistent glycosylated hemoglobin of 10% should reassure parents that diabetic nephropathy is unlikely in the future. And the only correct answer is C. Doses should not be omitted with physical activity but may need to be reduced. In febrile illnesses, blood glucose levels are usually high due to stress. In a majority, non-compliance is a cause for diabetic ketoacidosis. A glycosylated hemoglobin indicates long-term diabetic control, and values under 7.5% are satisfactory. Those over 10% indicate the possibility of complications in later life, such as nephropathy. Let us now examine question 4. Vicky is a 15-year-old child with type 1 diabetes, which was diagnosed 3 years ago. She is on a mixed insulin. She has 8 units in the morning and 13 units in the evening. For the past 2 months, her finger prick blood glucose levels have varied between 8 and 15 millimoles per litre in the pre-lunch period. Why may this be the case? Choose one answer, please. A. Too much carbohydrate in the diet. B. Not enough insulin in the morning. C. Not enough insulin in the evening. D. A coexisting chronic illness. And E. Not enough exercise. And the answer is B. It's very unlikely that too much carbohydrate in the morning will lead to high sugar levels. Note that this child is on an unusual regimen where the morning dose is less than the evening dose. Therefore, in this child, the morning dose of insulin needs to be increased. Diabetic ketoacidosis is a complication of type 1 diabetes where there is metabolic decompensation with an anion gap. Please note that bicarbonate usage is inadvisable unless the acidosis is severe with a pH of less than 6.9, if the acidosis is refractory, if the potassium is unusually high, or the child has a circulatory collapse. When treating children with diabetic ketoacidosis with insulin, as the blood glucose levels drop, add more dextrose rather than stop the insulin infusion. Please note that over-treatment, particularly with fluids, may cause cerebral edema. Let us now examine this question. Kevin is a 5-year-old child and has presented with diabetic ketoacidosis. Cerebral edema is likely because of the following. A drop in blood glucose from 40 millimoles per litre to 20 millimoles per litre. B. The initial pH was 7.2 and the base deficit was minus 22. C. Sodium bicarbonate was not given. D. The initial serum sodium was 140 millimoles per litre. E. He received 3 fluid boluses of 20 mils per kilogram in addition to fluid correction over 24 hours and maintenance fluids. The drop in blood glucose is rather drastic, and one should attempt not to lower the blood glucose by more than 5 millimoles per litre per hour. Therefore, A is correct. The initial pH did not suggest significantly poor metabolic acidosis. The fluid boluses were in excess of recommended guidelines and probably contributed to cerebral edema. The fact that sodium bicarbonate was not given is good management. The initial sodium was normal and therefore should not contribute to cerebral edema. We now move to insulin resistance rather than insulin deficit, as in type 1 diabetes. Insulin resistance can lead to type 2 diabetes. With the increased obesity rates across children, this has become more important. Insulin resistance has been associated with the polycystic ovarian syndrome. There are predisposed populations, Asian children, those with a family history of type 2 diabetes. The diagnosis of insulin resistance is on the glucose tolerance test. If you measure glucose and insulin concomitantly on fasting and postprandial blood samples. In the skin, you may see changes of acanthosis nigricans. In this picture, you have on your left-hand side the skin over the neck, which is rather leathery in appearance, pigmented and thickened. Same also on the right-hand side in the axillary region. Obesity is increasingly common, and the commonest cause of obesity is nutritional. With excess weight gain comes insulin resistance, which may lead to type 2 diabetes. The cornerstones of treatment for for obesity are healthy lifestyles. Although there is genetic predisposition to obesity, monogenic causes of obesity are rare. There are several endocrine causes of obesity, as in the list. Children with Prader-Willi syndrome may have neonatal hypertonia, learning difficulties, and small genitalia. Those with Cushing syndrome are short and overweight. Those with pseudohypoparathyroidism are also short, usually have learning difficulties. This is a chart of body mass index. As you see, BMI increases through childhood. Between age 3 and 5, there is a dip in BMI, known as the adiposity rebound. This child's BMI in the black dots has been plotted and suggests the child is increasingly overweight from an earlier age. The loss of adiposity rebound seen in this child predicts the presence of insulin resistance in mid-childhood. This is one cause for developing insulin resistance in later life. The child on the right-hand side is small and has a birth weight of less than the second centile, and by definition is known as small for gestational age, or SGA. A proportion of children catch up in height and weight and may be predisposed to developing insulin resistance if they become overweight. The regulation of adiposity occurs at the level of the hypothalamus, involving pathways known as leptin-melanocortin pathways. One aspect in that pathway involves the melanocortin receptor 4, which, if mutated, can cause significant obesity. Note that in conditions such as a craniopharyngioma, there is damage to the hypothalamus, which can lead to obesity. This slide is one of Prader-Willi syndrome. On the right upper corner is a child with neonatal hypertonia, which is typical of Prader-Willi syndrome. In the first few months of life, the child has a poor suck because of poor muscle tone, which then reverses at around the second birthday. Thereafter, the child has an insatiable appetite and puts on weight. This child has leptin deficiency. The one on the left-hand side was pre-treatment. The one on the right-hand side was after treatment with leptin. This is to remind ourselves that leptin has an important role in hypothalamic pathways regulating appetite and satiety. However, leptin-deficient children are exceedingly rare. Let us now examine this question. A 14-year-old Asian girl is overweight and has been gaining weight over the past 2 years. She enjoys her food and does not like physical activity. Her parents are also overweight, and her father is on metformin. Her height is on the 91st centile and her weight is well above the 98th centile. Acanthosis nigricans is observed in her axillae. Which investigation is most likely to be useful? A. 24-hour urine-free cortisol. B. Fasting plasma lipids. C. Fasting plasma glucose. D. Oral glucose tolerance test with insulin and glucose levels. And E. Chromosome analysis. And the answer is D, because the oral glucose tolerance test helps you measure insulin and glucose levels, thereby determining insulin resistance and the presence or absence of type 2 diabetes on the glucose values. In this question about polycystic ovarian syndrome, choose the correct statements. Hirsutism is a common complaint. The finding of multiple cysts on ovarian ultrasound is mandatory to the diagnosis. Irregular periods are due to ovarian hyperandrogenism. Surgical treatment is recommended. Estrogen-containing preparations may suppress LH-mediated androgen secretion. And the answers are A, B, C, and E. In polycystic ovary, androgens make children hirsute. Not all children have the cystic appearance in the ovaries on ultrasound scan examination. If the ovaries are making excess androgens, they cause irregular periods. Surgical treatment is rarely indicated. Estrogen-containing preparations such as the contraceptive pill may suppress LH-mediated androgen secretion. Let us now examine excess insulin causing hypoglycemia. There are several causes of hypoglycemia apart from hyperinsulinism. These may be metabolic, such as medium-chain acyl-CoA dehydrogenase deficiency, galactosemia or glycogen storage disorders. Rarely, you may have growth hormone deficiency or adrenal insufficiency presenting earlier in life with hypoglycemia. If you have detectable insulin in the presence of hypoglycemia, the likely diagnosis is congenital hyperinsulinism. This is a child with congenital hyperinsulinism, or CHI, at birth, and he weighed 6.6 kilograms and needed treatment for hyperinsulinism. Congenital hyperinsulinism is the commonest cause of persistent hypoglycemia in infancy. If insulin levels are detectable when the glucose levels are low, i.e. less than 2.6 millimoles per liter, this indicates the diagnosis. Excess insulin suppresses ketone production. Therefore, the neonatal brain is starved not only of glucose but also of ketones. Therefore, the neonatal brain is susceptible to hypoglycemic injury. In some children, recurrent hypoglycemia may affect cognitive behavior and the visual occipital cortex, leading to poor vision in later life. This condition is mostly genetic, with mutations now identified in the potassium-sensitive ATP channel genes. A proportion of children with CHI are responsive to diazoxide, other children are not, and they need octreotide treatment to lower insulin levels. By and large, there are two forms of HI, diffuse and focal. In those children with diffuse CHI which are not responsive to medical treatment, subtotal pancreatectomy may be necessary. In focal CHI, the treatment of choice is a focal lesionectomy. This is a slide of focal congenital hyperinsulinism on PET-CT scan. This investigation is the investigation of choice to determine whether a child has a focal or a diffuse disease. The white arrow indicates the position of the focus within the pancreas, which is amenable to surgery and helps the surgeon localize the lesion very accurately. Let us now examine this question. The following are recognized causes of significant hypoglycemia: congenital hyperinsulinism presenting at 10 months of age, 3-beta-hydroxysteroid dehydrogenase deficiency, congenital adrenal hyperplasia, Laurent syndrome, Biel-Bardet syndrome, and Cushing syndrome. And the answers are A, B, and C. Congenital hyperinsulinism may present at a later age. There are different types of congenital adrenal hyperplasia, of which a rare variety is 3-beta-hydroxysteroid dehydrogenase. Like 21-hydroxylase deficiency, these children have adrenal insufficiency, which may cause hypoglycemia. In Laurent syndrome, there is growth hormone resistance, which may cause hypoglycemia. The key learning points in this lecture are, therefore, that potassium-sensitive ATP channel is a key insulin regulator, and may be mutated in congenital hyperinsulinism. Type 1 diabetes is predisposed by specific HLA loci. Obesity is increasingly common and causes insulin resistance, which may lead on to type 2 diabetes. Congenital hyperinsulinism, although rare, is the commonest cause of persistent hypoglycemia in infancy.